Good evening, everyone. I welcome you all to this session of oral pathology. Please let me know if I am audible and if I can see my screen. Please let me know if I am audible and if you can see my screen. Please type it in the chat box so that we can go ahead. Yes. Okay. So in this session of oral pathology, I'll be covering some of the important MCQs based on some concepts, based on some images. Okay, so where we will try to solve certain concepts, we'll try to understand certain concepts. Okay, thereby we will better understand the concepts, and we can, so that we can use these concepts to solve the various MCQs. Okay, audio is bit low. Fine, I'll just try to see that the audio will see that. Okay, so now coming to the first question here. The first question says that a 78-year-old patient presented with small symptomless localized swelling. So the question here, see, look at the question, try to understand, try to pick up the important points in the question. Okay, symptomless, that means patient has got no complaints. So patient has got no complaint. It is a symptomless swelling. It's a localized swelling on the right inferior alveolar process. So this patient is having swelling on the alveolar process. No regional lymphadenopathy. No regional lymphadenopathy. So lymph node, if you examine, palpate the lymph nodes, there are no regional lymph nodes. OPG shows a radiolucent oval shaped unilocular area. So that means there is a oval shaped area, unilocular area. Microscopic examination revealed numerous follicular odontogenic epithelial islands. So there are some follicular islands with the amyloblast like cells on the periphery and central stellate reticulum like cells. In few of the islands, the center of the islands shows squamous metaplasia. The probable diagnosis. See, look at these terms here. So here what has happened is, the question says that there are odontogenic islands, and the odontogenic islands has got a peripheral cells with the central tall column with central stellate reticulum like cells. Peripheral cells are tall columnar, central cells are loose stellate reticulum like cells. But some of these cells have undergone metaplasia. Metaplasia means what? It is a differentiation, conversion of one adult type of cell to the other adult type of cell. That is called as metaplasia. Now the stellate reticulum cells have undergone metaplasia and started producing keratin. So in the islands, in the odontogenic islands, we will see some keratin like structure within these islands, odontogenic islands. So that means that for example, this is the odontogenic island. Within this island instead of stellate reticulum, I'll be able to see structures like this. That is keratin. That is keratin. So whenever you see keratin within odontogenic islands, you should search, first thing you should suspect is could be a acanthomatous ameloblastoma. Could be a acanthomatous ameloblastoma. Okay, so acanthomatous ameloblastoma is equal to follicular ameloblastoma plus squamous metaplasia of stellate reticulum like cells. Stellate reticulum like cells. So if you see combination of these two, that helps us to come to a diagnosis that this is acanthomatous ameloblastoma. Okay, acanthomatous ameloblastoma is equal to follicular ameloblastoma plus squamous metaplasia of stellate reticulum like cells. In this image, try to see here that this is the swelling. This is a swelling, and you can note here the unilocular radiolucency. So there is a unilocular radiolucency there, and there is a swelling there within the alveolar process. Okay, so by this, now how can we rule out a squamous odontogenic tumor? Even a squamous odontogenic tumor can give the same features. How do I prove that this is not squamous odontogenic tumor? This is not squamous odontogenic tumor. How can I say that is? Squamous odontogenic tumor basically will not have those peripheral cells. It will have no peripheral palisading cells. No peripheral palisading cells. If they are seen also, and there won't be any prominent stellate reticulum like cells. No prominent stellate reticulum like cells. So these two features will not be seen in squamous odontogenic tumor. By that way, we can rule out that this is not squamous odontogenic tumor. Okay, but you can see keratin. You can see keratin in SOT. SOT is squamous odontogenic tumor. You can see keratin. But how do I differentiate? In follicular ameloblastoma or acanthomatous ameloblastoma, I'll be able to see tall columnar peripheral cells. Okay, and in the center, I'll be able to see stellate reticulum like cells. And some of those stellate reticulum cells have undergone metaplasia into squamous cells. And they have started producing now keratin. So by this way, I can rule out SOT, squamous odontogenic tumor. How do I rule out follicular ameloblastoma? Because follicular ameloblastoma doesn't contain squamous metaplasia. Squamous metaplasia means follicular ameloblastoma plus, acanthomatous ameloblastoma means follicular ameloblastoma plus squamous metaplasia. How do I rule out unicystic ameloblastoma? Because unicystic ameloblastoma doesn't contain follicles. What is unicystic ameloblastoma? It is just a lumen, a lining, and a capsule. It is a cyst. It is ameloblastoma which has got cystic appearance. So what a cyst will contain basically? A cyst has got three parts, right? A cyst will contain a lumen, cyst will contain a lining. This is a lining, and outside what we have in the cyst is capsule. So unicystic ameloblastoma will have ameloblastoma changes here, which can enter here or which can enter into capsule. So it will have a cystic pattern which is absent in the given case. So by this way, we can rule out that this is not unicystic ameloblastoma. Okay, right? So this is the way you have to solve the MCQ and try to understand. So never blindly follow the answers or mug up the answers for any MCQ. Think logically, try to rule out. Okay, Why it is not SOT? Find out the reason why it is not SOT. Once you ask a question, then only you will get an answer. Okay. Now next question. An inherited condition with sparse hair, periocular hyperpigmentation, and mild midfacial hypoplasia, and oral manifestations in the color plate. These are, if you can see here, characteristically the question is of ectodermal dysplasia. Why I say ectodermal dysplasia? Because we know that in ectodermal dysplasia all ectodermal structures are affected. Skin is affected, hair, nails, teeth, sebaceous glands, sweat glands, all these are affected, right? So the individual will have sparse hair, fine hair, and around the eyes there will be hyperpigmentation. Okay. And if you see the teeth specifically, the two most important oral manifestation of ectodermal dysplasia. One is the patient will have oligodontia. If you look at the image, the patient will not have all the teeth. There will be absence of many teeth. Okay, that's the first point. Or sometimes, rarely you can see even anodontia. Where the complete set of teeth is only absent. Okay, that's a rare finding. And whatever teeth are there, look at the shape of this. Look at the shape. Typically, they are conical or cone shaped, which is also described as peg shaped. Okay, so the ectodermal dysplasia, two most important oral manifestations is oligodontia and peg shaped or cone shaped teeth. So this is the correct answer, ectodermal dysplasia. Okay, so very important in ectodermal dysplasia, which I want you to remember, all of you. Ectodermal dysplasia is X-linked recessive disorder. One of the very important concept about ectodermal dysplasia is it is X-linked recessive disorder. Any kind of X-linked recessive disorder, usually they follow something called as Lyon's hypothesis. Okay, this is a very important concept you have to understand. Lyon's hypothesis. What is Lyon's hypothesis? Lyon's hypothesis says that, or substantiates that, males are more severely affected and females are less severely affected by any kind of X-linked recessive. Let it be hemophilia, let it be ectodermal dysplasia, in any kind of X-linked recessive disorder, males will be more severely affected and females will be less severely affected. That is what is known as Lyon's hypothesis or Lyonization. Okay, so this is one of the important concept. Whenever ectodermal dysplasia, a question on ectodermal dysplasia, or you read anything about ectodermal dysplasia, this Lyon's hypothesis should immediately come to your mind. So by that way, what will come? What you will think? Yes, usually the severe features, let it be total absence of teeth, let it be hypotrichosis. Hypotrichosis is less sparse hair. Okay, hypohidrosis, like less sweating. All these features are more severe in males and it is less severe in females. Okay, so that is about ectodermal dysplasia. Moving on to the third question. A 50-year-old male patient. So first point here, patient is a male patient. Presented with a hard swelling at the posterior to the angle of the mandible. That means near the angle of the mandible there is a swelling. And patient is a smoker. Histologically, examination revealed the following features. Look at the image here. First of all, this is a characteristic image I want all of you to understand this image where there is a cyst here, cystic space. All of you can appreciate the cystic space, and you can appreciate this epithelium which is bilayered. Okay, two layer, one layer is here, one layer is here. It is a bilayered papillary epithelium. Sorry, this is a bilayered papillary epithelium. Okay, and we can also note here there is a lymphoid component here. There is a lymphoid component. Okay, so by understanding these three components, that there is a cystic space, there is a papillary layer, there is a lymphoid component, it is nothing but Warden's tumor. Warden's tumor. So always remember this, that and first of all, if you look at this question, patient is a male patient because Warden's tumor frequently occurs in males. Okay, and it is at the angle of the mandible. Obviously, near the angle of the mandible, we have the parotid gland. Okay, so behind we'll have a parotid gland. So it is involving parotid. Patient is a smoker. We know that smoking is one of the predisposing factor for Warden's tumor. Smoking is one of the predisposing factor for Warden's tumor. Okay, so male patient, parotid involvement, smoker, with the histological features of three components: cystic lumen space, papillary layer of the epithelium, and lymphoid component. It is Warden's tumor. So what is Warden's tumor after all? It is also known as papillary cyst adenoma lymphomatosum. Lymphomatosum. Papillary cyst adenoma lymphomatosum. Okay. Now, one of the important concept which we should know about this Warden's tumor is, this Warden's tumor is also, radiation is also one of the predisposing factor. So individuals who are exposed to radiation are susceptible to develop this. Okay, one more salivary gland malignancy, mucoepidermoid carcinoma, is also secondary to sometimes radiation. So we should remember that radiation is one of the predisposing factor for Warden's tumor. Radiation is one of the predisposing factor for mucoepidermoid carcinoma. Okay. One more concept we should know about this lymphoid follicle is, lymphoid follicle is always susceptible, or it is lymphoid follicle usually attracts technetium-99, because technetium-99 usually it deposits, or it is isolated, or you can say it accumulates at the site of lymphocytes. Wherever the site of lymphocyte aggregation is there, technetium-99 positivity will be seen. So this is known as hot spot. So we should note that Warden's tumor demonstrates hot spot using the technetium-99 scan. Okay, so this is also one of the important component that we should know about the Warden's tumor. Okay, so moving on to the fourth MCQ here. A patient came to a dental clinic with burning sensation in the mouth. So patient has got burning sensation in the mouth. Patient also gives a medical history of hepatitis C virus. Okay, now patient typically has got so this is color plate, leave it this the color plate. So patient gives typically which of the following characteristics is observed on the biopsy of the given lesion. So basically the patient, what the symptoms, two important components you have to understand here is, one is burning sensation of the mouth and association with hepatitis C virus. Hepatitis C virus. Burning sensation of the mouth and hepatitis C virus, always what should come to your mind is lichen planus. Lichen planus is the one which you should know can be associated with hepatitis C virus. Okay, very important one. If in the same question, instead of, if I say a patient comes to a dental clinic with a swelling of the parotid gland, and patient gives a medical history of hepatitis C virus, then what should come to my mind? Swelling of the parotid gland and hepatitis C, Sjogren syndrome should come to your mind. So hepatitis C, basically, hepatitis C is a predisposing factor. It is a predisposing factor for two things in the oral cavity. See, I'm talking about specifically in the oral cavity. It's a predisposing factor for two things. One is lichen planus, LP. One more is Sjogren syndrome. So these two patients are highly susceptible to develop Sjogren's, to develop hepatitis C. Is a predisposing factor for these two conditions, that is LP, lichen planus, and Sjogren's. So here the patient is typically giving a complaint of burning sensation of the mouth, and we know that lichen planus has got burning sensation of mouth. So in this, if you see the clinically, the histopathological feature, candidal hyphae in the epithelium. No, candida is not associated with hepatitis C. And basal cell degeneration. Yes. So this is the one. We should know that this is the correct answer. Why? Because lichen planus shows liquefaction degeneration of basal cells. We know that basal cells of the epithelium are the target in lichen planus. They are destroyed by the CD8 T cells. So we know that CD8 T lymphocytes, CD8 plus T lymphocytes, they will attack the basal cells of the epithelium. Basal cells of the epithelium are basically destroyed. Okay. Another way, they will undergo liquefaction degeneration. They will undergo apoptosis. Okay. So basically, this lichen planus is a cell-mediated autoimmune disease. It is basically a cell-mediated autoimmune disease. So it is autoimmune, but mainly cell-mediated. So mainly the T lymphocytes, that is CD8 T lymphocytes, are going to cause the liquefaction degeneration of the basal cells of the epithelium. Okay. So by this way, we can rule out that this is not the other options. We can rule out intraepithelial acantholysis. Intraepithelial acantholysis. See, this word acantholysis, whenever it comes to your, you can see this is suggestive of pemphigus. Because in pemphigus, what happens? Desmosomes are destroyed, hence the cells will lose their attachment. That is called as acantholysis. The spinous layer cells will lose their attachment. That is known as acantholysis. So intraepithelial acantholysis, that means within the epithelium, within the suprabasal cells, that is suprabasal cells, basically the cells will lose their attachment. That is called as intraepithelial acantholysis, which is characteristic of pemphigus. Okay, moving on to the fifth question here. In contrast to other variants of squamous cell carcinoma, spindle cell carcinoma stains positively with. So there are various variants of squamous cell carcinoma, but spindle cell carcinoma stains positively with vimentin. Why? I'll tell you. So here in this question, what are we supposed to remember? There is a technique called as immunohistochemistry, IHC, immunohistochemistry. What this technique will tell us, it will use a marker for specific tissue. For specific tissue, there will be a specific marker. For example, for epithelium, what are the markers? Markers are cytokeratin, P63, epithelial membrane antigen, EMA. All three are epithelial markers. Whereas for connective tissue, we have a marker called as vimentin. Now comes the question, why is a carcinoma? Carcinoma means what? Malignancy arising from epithelium, right? So why a carcinoma is showing a connective tissue? marker positivity. So to understand that, we should know that spindle cell carcinoma is basically a biphasic tumor. It is basically a biphasic tumor where it will have two types of cells. It will have epithelioid cells and it will have epithelioid cells and it will have spindle shaped cells. And those spindle shaped cells are basically Vimentin positive. They are basically Vimentin positive. Okay, so basically this is a biphasic tumor where we have epithelioid cells and spindle shaped cells, and these spindle shaped cells are basically Vimentin positive. Okay, so that's about the spindle cell carcinoma. Now moving on to the next question. Identify the given below condition. If you look at the image itself, this is very characteristic image where you can see all the teeth here which have a blurred appearance, and we are not able to identify where is the dentine, where is the enamel. So enamel and dentine have lost their radio density. So this is a feature of ghost teeth. Ghost teeth. What is ghost teeth? Ghost teeth is regional odontodysplasia, where we will not be able to see the difference, radio density between, we will not be able to differentiate or radio density of enamel and dentine is same. That is nothing but your radio density of enamel and dentine is the same. So usually enamel is more radio dense, dentine is radio lucent. So that difference is lost in case of ghost teeth. That difference is lost in case of ghost teeth. Okay. Now what is bull teeth? Bull teeth is taurodontism. Bull teeth is taurodontism. What is cadepon teeth? Where do you see that? In dentinogenesis imperfecta. Where do you see shell teeth? Dentinogenesis imperfecta type 2. DI, dentinogenesis imperfecta type 2. Okay, all of we are usually MCQs will come on this: shell teeth, cadepon teeth, bull teeth, ghost teeth, Turner's teeth. Okay, so these are very commonly fashionable questions which are very frequently asked. These terms, they are very frequently asked. Okay, moving on to 7th question here. A histopathological spectrum showing interlacing bundles of spindle shaped cells with wavy nuclei interspersed with delicate collagen fibers and with occasional presence of mast cells. So here, so if you look at the question says that the cells are spindle shaped. The nuclei that you see here are wavy nuclei, and the cells have basic, and this particular lesion has got numerous mast cells. Whenever you see mast cells plus wavy nuclei, combination of these two, mast cells plus wavy nuclei, always remember it is neurofibroma. Always remember it is neurofibroma. So neurofibroma is one of the most common benign neoplasm of nerve, which usually demonstrates wavy nuclei. Okay, and you can see presence of numerous mast cells. So how do you demonstrate mast cells? What special stain can be used for demonstrating mast cells? Toluidine blue. So if we are not able to see it under the light microscope using HND stain, hematoxylin and eosin stain, we should use this toluidine blue for mast cells. So mast cells, whenever you see mast cells, first thing that should come to your mind in oral pathology is neurofibroma. Okay, neurofibroma. Okay, which of the following belongs to Wicker-Gorlin criteria? Wicker-Gorlin criteria. So here, if you see carefully, instead of fourth, instead of fourth, all are the other correct. 3. So what is Vickers-Gorlin criteria? Vickers-Gorlin criteria is for ameloblastoma transformation. The word important here is transformation or conversion. For example, if a dentigerous cyst converts into a ameloblastoma, transform into ameloblastoma, it has to satisfy this Vickers-Gorlin criteria. What are those criteria? I'll just highlight that: reversal of polarity of the nucleus, subnuclear vacuolization, nuclear hyperchromatism, nuclear palissading. Okay, so all these are nothing but the Vickers-Gorlin criteria, which are characteristic of the ameloblastomatous transformation. So that is the reason histology of dentigerous cyst is very important. So we know that if the impacted tooth, we can have a dentigerous, an individual can have a dentigerous cyst. So histological examination of that dentigerous cyst is very important, because sometimes what happens is, suppose this is the cyst, dentigerous cyst, right? In only one area, this area, the epithelium, the cystic epithelium is showing, the cystic epithelium is exhibiting these features. What? Vickers-Gorlin criteria. That means that it is just not a dentigerous cyst now, it has converted into ameloblastoma. That is why thorough evaluation of the histopathology of dentigerous cyst is very important, because one of the complications of dentigerous cyst is it can become ameloblastoma. So how to prove that? Look at this Vickers-Gorlin criteria. If the Vickers-Gorlin criteria is satisfying, then it is basically a ameloblastomatous transformation or ameloblastomatous conversion. Let us move on to the 9th question here. The given below picture shows a condition caused because of infarction into the area, which gradually healed in the process. So looking at this image, if you see here, what they'll give is, first question, the history says that because of infarction. What do you mean by infarction? Infarction means reduced blood supply. Why blood supply has reduced? Because of heat or smoking. So this is particularly a case where the etiology is heat. Heat from where? Heat from the smoke. And because of this heat, the palate has undergone ischemia, and because of this ischemia or infarction, you are able to see a palatal ulcer. So this is a typical case of necrotizing xylometaplasia, where we will be able to see such an ulcer. Look at this ulcer. How does it look like? It looks like a deep ulcer. It looks like a deep ulcer. So ulcer that is described in here is crateriform ulcer. Crateriform ulcer. So in necrotizing xylometaplasia, typically a male patient as a smoker with a deep, large crater-like ulcer that is seen on the palate. Okay, the cause or the etiology here is not the carcinogens present in the smoke. Here it is the heat that is produced because of smoking is going to cause ischemia, which is going to cause necrosis. Thereby, you will see a palatal ulcer. Okay, remember that this is self-healing. This is self-healing. Okay, no treatment is required for this. And as it clinically mimics carcinoma, it looks like carcinoma. Sometimes, it is self-healing. It looks like the carcinoma. Okay, so but no prompt treatment is required. No specific treatment for this. Follow-up of the patient and histopathology should be done. Histopathology should be done. Okay, so that proves that histopathology is only gold standard for diagnosis. Is gold standard for diagnosis. Why? Because in this condition, we are not going to see invasion. In carcinoma, we will be able to see invasion. Whereas here in this necrotizing xylometaplasia, we are not going to see any kind of invasion. Okay, what is invasion? The epithelial cells break the basement membrane and enter into the connective tissue. That is called as invasion. So which is usually absent in case or not seen in case of necrotizing xylometaplasia. Moving on to the 10th question here. The precursor cells that are lost or reduced in number resulting in symptoms of malformation of ear, facial clefts, hypoplasia of the facial bones, skeletal deformities in mandibulofacial dysostosis are. So the question here is simple. What is mandibulofacial dysostosis? It's also called as Treacher-Collins syndrome. Treacher-Collins syndrome. So what happens in Treacher-Collins syndrome? There is a gene mutation called as TCOF1 gene mutation, right? And this gene mutation, what it is going to result in? It is going to result in the loss of neural crest cells. So neural crest cells, which usually migrate to the developing brain area, so there they won't migrate. So that results in the mandibulofacial dysostosis. So here the question important thing is, which cells are lost here? Basically it is nothing but neural crest cells. So main problem in the Treacher-Collins syndrome is the gene mutation, that is TCOF1 gene mutation, which is going to result in the loss of these neural crest cells. Coming on to the 11th question. False statement regarding black hairy tongue is, we know what is black hairy tongue. On the surface of the tongue, we will be able to see the blackish lesion. Okay, it is a condition caused by chromogenic bacteria. That's true. It's true. Candida albicans is the main predisposing factor. That's a false statement. Black hairy tongue has got nothing to do with Candida albicans. Patient may complain of pain or burning sensation. Yes, patient might have pain or burning sensation. Elongation of filiform papillae. So in black hairy tongue, why black hairy tongue is seen? Basically because of the hyperplasia of filiform papillae. So there is nothing to do with the Candida in case of black hairy tongue or hairy tongue. Okay, so Candida is not associated with a hairy tongue. That is a concept, single liner MCQ that is frequently asked. So we should be aware of this fact. True among the following about cysts is, odontogenic keratocyst has a thin epithelial lining of uniform thickness with a 2 to 3 layered. So first thing, what are we going to do here? We are going to find out the false statements. What are the false statements? Yes, this is a false statement. Why it is a false statement? Because odontogenic is EBV associated with black hairy tongue. Not exactly associated. See, it can be seen, it can be isolated, but not in the etiology. It is not associated with the etiology. You can isolate it in the, it can be seen isolated. You can isolate that on the tongue, but not associated with the etiology. OKC has a thin epithelial lining of uniform thickness with 2 to 3 layers. No, that's a false statement, because OKC layer is usually around 6 to 8 layers. Radicular cysts have epithelial lining composed of stratified squamous epithelium. That's true. That's the true statement. So we have got one true statement. Let us see other statements. Epithelial lining in aneurysmal bone cyst is columnar epithelium. That's a false statement, because aneurysmal bone cyst is a pseudocyst. ABC is basically a pseudocyst. It doesn't have any kind of no lining epithelium, no epithelium. So that's a false statement that we are able to see columnar epithelium in aneurysmal bone cyst. Cholesterol clefts within the cystic wall are pathognomonic of radicular cyst. That means whenever you see cholesterol clefts within the wall of the radicular cyst, within the wall, always it is suggestive of radicular cyst. No, that's wrong, because cholesterol clefts can be seen in any inflammatory condition. It is not always that it is seen only in case of radicular. Any inflammatory lesion, let it be a periapical granuloma, let it be infected dentigerous cyst, let it be infected OKC, in any of these conditions, whichever are infected, inflammatory, we can see cholesterol clefts. We can see cholesterol clefts. So the correct answer here is radicular cysts have epithelial lining composed of stratified squamous epithelium. Let us move to the 13th question. Which of the following microscopic pictures of the following condition does not show formation of keratin plugging? That means, what do you mean by keratin plugging? On the surface, suppose this is the epithelium. This is the epithelium. On the surface, it will show keratin like this. Keratin like this. That is called as keratin plugging. Okay. So keratin plugging is a feature of Ackermann's tumor. Yes, in verrucous Ackermann's tumor is other name for verrucous carcinoma, where we see specifically the keratin plugging. Keratoacanthoma we can see, Fordyce's granules we can see, not in basal cell carcinoma. Not in basal cell carcinoma. Fordyce's granules, what is Fordyce's granules? Fordyce's granules is nothing but ectopic sebaceous glands, which we see in the oral cavity. So remember that pathognomonic means characteristic. Pathognomonic means characteristic. For example, if I say satellite cysts are pathognomonic for OKC. Whenever that comes to my mind, first thing that should come to mind, satellite cyst means OKC. That is pathognomonic. Okay. So which of the following microscopic features? So you have to remember that all these first three MCQs, three options, they will show keratin plugging, which is absent in the basal cell carcinoma. Multiple intestinal polyps, osteomas, multiple epidermoid cysts, desmoid tumors, impacted teeth, all are features of single liner MCQ, very commonly asked. Gardner syndrome, very, very frequently asked. Okay, you can put it a star mark for this question, very frequently asked, because you see multiple things in Gardner syndrome. You see multiple osteomas, you see multiple impacted teeth. One more impact that is not there in this here. You also see multiple dentigerous cysts in these patients. So three important multiples that you see in the oral cavity: multiple osteomas, okay, multiple osteomas, multiple dentigerous cysts, multiple impacted teeth. All these three are characteristic of the Gardner syndrome. All these three are characteristic of Gardner syndrome. Okay, so Gardner syndrome is the one where you will see multiple. Forget about the epidermoid cyst, desmoid tumor. What you have to remember in the oral cavity: multiple osteomas, multiple impacted teeth, multiple dentigerous cysts. Okay, moving on to the 15th question. The desmoid tumors. Desmoid tumors are related to skin. Okay, these are some lesions that are seen on the skin. The odontogenic cyst with the predilection to occur in the anterior mandible and also has the tendency to cross the midline. So the only odontogenic tumor or odontogenic cyst which can cross the midline. For example, if this is the jawbone, okay, if I say that this is the midline, the glandular odontogenic cyst will always occur like this. It will be crossing the midline on either side of the midline. Okay, it will not be located on one side of the midline, both the sides, and it is typically present in the anterior mandible. That is a glandular odontogenic cyst. Okay, again a very characteristic single liner MCQ that we are supposed to know about this glandular odontogenic cyst, which is also known as mucoepidermoid or siloodontogenic cyst. It is also known as siloodontogenic cyst. Okay, moving on to the 16th question. Which of the following is not a candidate gene that is implicated in the causation of non-syndromic cleft lip and cleft palate? First point that we should know about the question, this is cleft lip, cleft palate is 95% of the cases are non-syndromic. That means they are not associated any syndrome. 5% of the cases are only syndromic here. 5% of the cases are basically syndromic. So in these genes, if you see, there is only one gene which is implicated in the etiology of a syndrome called as van der Waals syndrome. What is that gene? IRF6. IRF6 is interferon regulatory factor 6. So it is a gene which is responsible for this syndrome, van der Waals syndrome. And this van der Waals syndrome is that is the reason that the other three are basically non-syndromic. So which of the following is not a candidate? Question says it's not a candidate for non-syndromic. The other three are non-syndromic cases gene, whereas the only one syndromic is interferon regulatory 6, which causes van der Waals syndrome. Please remember this point. Interferon 6 causes van der Waals syndrome. Okay, moving on to the 17th question. The teeth showing numerous pinpoint pits. So teeth is having a lot of pinpoint pits scattered across the surface of the teeth, and the enamel between the pits is of normal thickness, hardness and coloration. And the enamel between those is normal thickness. The most probable diagnosis is simple. Remember, hypoplastic amelogenesis imperfecta. Whenever you see pitting enamel with brownish discoloration, okay, the thing that should come to your mind immediately is hypoplastic type of amelogenesis imperfecta. So there are different types of amelogenesis imperfecta: hypoplastic, hypomaturative, hypocalcified. Hypoplastic is the one which typically shows pitting type of pattern. Okay, again, that can be a typical image based MCQ where they will give you an image, a tooth, where there are on the surface of the tooth you are able to see a lot of pits, and those tooth also they have basically discoloration, brownish discoloration. So this is a feature of hypoplastic amelogenesis imperfecta. Okay, moving on to the last question for today's discussion. Which of the following is an important criteria to distinguish between Mikulicz disease from Sjogren's syndrome? So we are able to see that there are tests given here in this MCQ, certain in this MCQ. Salivary and lacrimal gland enlargement is an important criteria. No, we can see in salivary and lacrimal gland enlargement in both the conditions. Schrimmer and Rose Bengal dye test positivity. Even though it is seen more in Sjogren's, it can also be seen in Mikulicz. Labial minor gland biopsy. Yes, it is an important criteria, but sometimes we can see even in the Sjogren's syndrome. But IgG4 antibodies in the serum, you don't see that in Sjogren's. You see this only in the Mikulicz. That is why Mikulicz disease is known as IgG4 related disease. What are IgG4 related diseases? IgG4 related diseases means these are the conditions where IgG4 level is raised. IgG4 levels is raised. For example, we have Behcet syndrome, right? So we have one syndrome called as Behcet syndrome, where the individual will have aphthous-like ulcers. It's IgG4 related disease. Mikulicz disease There we can, this is IgG4 related disease. Then we have something called as Kuttner's tumor. What is Kuttner tumor? Where the typically we call it as chronic submandibular sclerosing silodenitis, where you palpate the submandibular gland, submandibular gland is very hard. That is called as Kuttner tumor. And sometimes we can see IgG4 related disease in something called as Wegener's granulomatosis also. So these are the conditions where we should remember that, where all we will see, be able to see the IgG4 related diseases. Okay, so even though labial minor salivary gland biopsy is a specific test for Sjogren's, you can also see that in Mikulicz. So you have to remember that the IgG4 level is very important here to estimate or to differentiate, because in Mikulicz, only in Mikulicz, IgG4 level will be raised, which will be normal in case of Sjogren's. Okay. So by this, just given you an overview how to solve the MCQs. Okay, its subject is very vast, oral pathology. If you read systematically this subject, so just 2 more minutes, I just want you to concentrate and prepare this subject in this manner. What I'm going to tell you now, next 2 minutes is very important. So try to understand the concepts, first point. Second, try to solve the MCQ. While solving the MCQ, directly don't mug up the answer. See the other options. Try to rule out the other options. Because while ruling out the other options, you are going to learn a lot of points. Okay. So by that way, you will see. By this, in this option, when we have learned about IgG4, we should know about IgG4 related disease. What are the IgG4 related diseases? We should be able to know that. Okay. So though that is the way you have to prepare, because oral pathology and oral medicine is a very vast subject. You need lot of preparation for this. So how to prepare this is, try to solve the MCQs, take out the important points from each option there that is given, try to write down it in one place and try to revise it frequently. Okay. So this is an overview how to solve the MCQs in the subject of oral pathology, because it's a vast subject. There are so many tumors, there are so many infections, there are so many diseases. Okay. So, and there are so many pathogenesis we have to understand, so many treatment modalities, some infections, skin diseases, pemphigus, we need to know the treatment, medications and all those things. So systematic approach is very much essential. So thank you very much. Any doubts? Any doubts from your side? Okay. So thank you very much. We'll end up the session now. Okay. Thank you.